Now, Alex Ford is an associate professor and honorary consultant gastroenterologist at St James's University Hospital in Leeds. He has been the author of a number of systematic, do you call it systemic or systematic reviews?
They are everywhere. So
they're everywhere.
No, systematic.
Systematic reviews and meta-analyses concerned with IBS. He is on the editorial boards of several international journals and has published over 230 peer-reviewed papers. So he is an excellent person to talk about research in IBS. So over to you, Leonie. What do we want from research?
This presentation, addressing what it is that IBS sufferers would like from research, is informed by experience and opinions of people living with the disorder. The questions that I ask arise from personal experience, as well as that of fellow sufferers, of diagnosis, management, and treatment of, as well as attitudes towards IBS. The patient wants a cure, guaranteed relief from symptoms, and to be reassured that there is nothing more sinister explaining the symptoms. We hope to explore whether there is congruence between that which patients want and that which clinical researchers pursue, and to inquire, what is the researcher's agenda? To the IBS sufferer, it seems that there is an absence of a clear, definitive cause to explain without any doubt the physiology that results in the symptoms experienced. It seems to be a multifactorial disorder, where likely causes and triggers vary from one individual to the next. It would appear that each sufferer's symptoms and experience are as unique as the individual himself. Therefore, is IBS an umbrella term for functional digestive disorders? It seems that there's no consistent trajectory and or globally effective treatment. How can we conduct research on a condition that is such an expression of the individual?
So thank you, Leonie, and good afternoon, everyone. I hope you can hear me. Many thanks for asking me to come and speak at short notice. I'm not Qasim Aziz, so if anyone came to see Qasim Aziz, I apologise. I'm here in his place. So in answer to Leonie's question, as a gastroenterologist, it's important to realise that disease of the gut can only really manifest itself in a limited number of ways. And for the most part, people like me, clinicians, rely on symptoms to guide investigation, diagnosis and treatment. Because there are only a limited number of symptoms that originate from the gut, this means that there's considerable overlap between symptoms that are felt to be compatible with functional gut disorders like irritable bowel syndrome and those of what we call organic diseases, so structural abnormalities in the gut, and those would include conditions like Crohn's disease, ulcerative colitis and celiac disease. So perhaps not surprisingly, the constellation, so the conglomerate of symptoms that we've seen in the presentations earlier this morning that make up the syndrome of IBS are really, exactly as Leonie suggests, an umbrella term. And I would say they probably cover a multitude of separate diseases of the gut for which, as yet, as scientists and as doctors, we don't understand the underlying explanation, but that provoke very similar symptoms in the people that have them because, as we've already said, there are only a limited number of symptoms that the gut produces. And this is probably reflected in part by the diversity of underlying abnormalities or potential what we call pathophysiological mechanisms that are reported in individuals with IBS, but which are often not reproduced between different studies. And these sorts of abnormalities are actually summarised quite nicely in Nick's piece in Gut Reaction in your bags, and include things like abnormal gut motility, which is where the contents of the intestine travel either too quickly or too slowly through the bowel, visceral hypersensitivity, which is an abnormal sensation of a heightened sensation of normal stimuli, abnormal processing of these stimuli from the nerve supply from the gut by the brain, so what we call abnormal central nervous system processing, disturbances in the intestinal microbiome, so the bugs in the intestine, low-grade inflammatory changes in the lining of the gut, and lastly, increased permeability of the gut, so the gut becomes leaky and allows the substances within its what we call lumen, the centre of the gut, to interact with the human body. So in future, research really needs to better separate out these potential underlying abnormalities that are found in people with symptoms that are compatible with or described as being irritable bowel syndrome, in order to understand the precipitating causes and therefore be able to develop newer and more effective treatment for people.
For IBS sufferers, digestive disturbance is often the indication that induces one to present to a GP, and conversely, the very reason for delay in presentation due to the intimate nature of symptoms. Each of us experiences an additional range of symptoms such as generalized pains and aches, fatigue, backache, headache, breathlessness. These are discrete from digestive function, yet apparently unexplained by other physiology, which leads us to question, why are exacerbations of IBS associated with these other seemingly unrelated symptoms?
Thank you, Lainey. No one really understands for sure why some patients with IBS report many other symptoms that are apparently unrelated to the gut, but studies have shown for certain that symptoms like back pain, joint pain, headaches, fatigue and trouble sleeping are all much commoner in people who report symptoms that sound like irritable bowel syndrome. So I would say there's probably several possible reasons why this kind of phenomenon occurs. The first thing to say is many of these symptoms are compatible with other functional disorders like fibromyalgia, tension headache and chronic fatigue, which, like irritable bowel, don't have any structural explanation. And these disorders are all seen much more frequently in people with IBS. Secondly, and again this is mentioned quite nicely in Nick's piece in Gut Reaction, chronic intestinal symptoms can have long-lasting effects on the brain. So the brain acts on the gut and the gut acts on the brain, and this is a bidirectional, we call it bidirectional effect, so top-down or bottom-up. So anxiety, depression and other disorders of psychological effect, such as a condition called somatization, can develop in people with IBS. But they can also develop in people with other gut disorders like Crohn's disease, ulcerative colitis and celiac disease. Somatization in particular is associated with the reporting of symptoms that are felt to arise from several different organ systems within the body. Thirdly, in some individuals, as I mentioned in my previous answer, there may be increased permeability of the gut, and this then allows substances within the gut lumen, so what we call antigens, whether they be from bacteria or from food, to interact with the individual's immune system. This could explain the low-grade inflammation of the gut lining that's seen in some people with irritable bowel syndrome. And any activation of the immune system can actually have far-reaching consequences because it then triggers off an inflammatory cascade which releases inflammatory substances into the bloodstream. And these can then go on to have multiple other effects at distant sites in other organs or body systems, and can also lead to inflammation elsewhere, such as in the joints, and can lead to more general symptoms such as fatigue and tiredness and trouble sleeping. The last thing to point out is that there's the possibility when a patient is reporting lots of other symptoms that aren't related to the gut, that the diagnosis of IBS is actually in doubt, and that the gut symptoms are being caused by another disorder like inflammatory bowel disease. So patients with inflammatory bowel disease or celiac disease often get inflammatory arthropathies and other conditions that are associated with having IBD or celiac disease, because they are partly autoimmune diseases, and I'm going to discuss that issue a little bit more later on.
Diagnosis is a challenging experience for sufferers. Apparently, a low percentage is believed to actually present to a physician to seek help. Anecdotally, GP consultations and diagnosis of IBS are frequently, at best, dissatisfactory. IBS is most often labelled probable and frequently just IBS. This augments sufferer anxiety due to a perceived lack of concern or knowledge, failure to acknowledge symptom severity and the impact on quality of life, and failure to educate the sufferer or to refer forward to an appropriate professional for further education and support. For the sufferer, this leaves room for doubt, and a lack of confidence in the physician compounds the notion that IBS is in one's head, and anxiety is recognised to aggravate the symptoms. If IBS is becoming better understood by doctors and researchers, and GPs are most often the first point of contact for IBS sufferers, how can this enhanced understanding be disseminated appropriately to promote greater confidence and a better experience for IBS sufferers in primary care, so that it can be proactively identified and addressed to optimize symptom control, promote function and quality of life, and reduce burden on the individual and the health service? How can we develop a useful model of an illness that affects both the gut and the mind?
So I think the first thing that most gastroenterologists who have any expertise in seeing people with IBS would say is that they would generally discourage general practitioners from telling patients that this is just IBS, because it's very well recognised from research that the symptoms of IBS are absolutely as debilitating as those of organic disorders like inflammatory bowel disease, so Crohn's and ulcerative colitis. As Leonie points out, though, GPs can struggle to be definite about a diagnosis of IBS. And this is because there's no single diagnostic test that can confirm the presence of the disorder. And as I mentioned earlier, there is often overlap of the symptoms that people with IBS report and those of other gut disorders. So this leads to uncertainty on the part of the GP that they're truly dealing with IBS. And then that uncertainty can then be compounded when the GP recommends a treatment and the patient or the person who is prescribed the treatment perceives a lack of efficacy, the treatment doesn't work. And so, therefore, that then leads to doubt of the diagnosis by the patient and a loss of confidence in the general practitioner's diagnosis. And remember that many of the treatments that we use first line are not that effective. So a lot of the discussion this morning about diet, this is being used increasingly first line, but many of the drugs we use first line, even now, because there aren't many dietitians around who have FODMAP training, and are not that effective. So what we really need from research is for it to identify and develop better tests to confirm a diagnosis of IBS, but also better treatments for the condition. Tests that are more accurate will increase the certainty among GPs and people with IBS that the diagnosis is correct. And more effective treatments will mean that when a GP tells someone that they have IBS and commences them on a treatment for their symptoms, there's likely to be an improvement in those symptoms, and therefore that reinforces in the person with IBS that the diagnosis is probably correct. Some studies are being conducted to improve methods of IBS diagnosis. Some of these are using newly developed biological markers, and one of these is available in the USA now. But there's also studies testing drugs that we already have established as effective treatments for other diseases, and also pharmaceutical companies are always developing and testing new drugs. But as Leonie alludes to, none of this is going to improve the experience of people with IBS in primary care unless the results of research like this is cascaded to GPs. A compounding problem, particularly in the UK, is that research into diagnosis and treatment of IBS has been an area really of low priority for investment versus some other diseases. And I think one of the beauties of organisations like this is that you can actually, in tandem with clinicians, create a sort of an agenda for future research with which research councils and government can be sort of badgered in order to persuade them that this is a priority for society as a whole. So things are improving in the UK, and there's some important research calls out from some of the research councils at the moment for IBS, but we still have a long way to go.
Currently, treatment is directed at predominant symptoms, and therefore few therapies demonstrate global benefit. There's a suggestion that the next 10 years will be revolutionary and a cure may be possible. Is this really likely or imminent? If the causes of IBS are not definitive, can a cure for all IBS sufferers be a real possibility? Will treatment recommendations for IBS be globally available? Is there currently a variation in treatment, for example, between Europe and the US? And following further research, will the most strongly recommended treatments be available to all? Realistically, will there ever be a cure for IBS?
So I found this the most difficult of Leonie's questions to answer. If one believes that IBS is a distinct entity and there's a single unifying explanation, then the possibility of cure of IBS is feasible, just as with any other condition. But I believe, and I'm sure many of you believe, that it's far more likely that IBS is a number of distinct conditions that present with very similar symptoms, as I mentioned in my first response. In most people, as the cause of these symptoms is unknown, there's no definitive treatment, and the symptoms are therefore chronic and they fluctuate. So these two features make cure of IBS probably unlikely and unrealistic, although I'm told by Leonard that someone in the US is saying that there will be a cure in 10 years. This is reflected by the fact that there are several treatments that are effective, several available treatments that are effective, proven to be effective in terms of improving symptoms, but none of these have ever been proven to cure IBS or to alter the long-term prognosis of IBS. There's variation between the available licensed treatments for IBS in some countries. In actual fact, in the UK, we're quite lucky. In the US, many of the treatments that we use are not available. The newest treatments that have been tested are available all in the US. Drugs like Constella, Eloxadiline and Rifaximin. In the UK, we have Constella is available, and Eloxadiline and Rifaximin will be available probably in the next year or so in Europe.
Finally, we frequently consider the possible causes and predisposing factors that contribute to IBS and are faced with its management and treatment on an ongoing basis, but little information is readily available about the future. Although I believe IBS does not cause any structural or permanent damage to the digestive tract, does an IBS sufferer have any associated risk of developing other diseases or disorders? Is IBS well enough understood, and has it been under investigation for long enough to have access to this kind of information? What is the long-term forecast for IBS sufferers, and what can we expect later in life?
So that's an excellent question, or series of questions. There have been numerous studies that look at the natural history of IBS symptoms, in other words, what happens to people with IBS in the long term, and fortunate in Leeds enough to have done one of those studies myself. So the bottom line from these studies is that, as I said in my previous answer, symptoms of IBS fluctuate and wax and wane. So overall, if people with symptoms compatible with IBS are followed up over 10 years, which is what we did in Leeds in one study, 2/3 of people will have chronic symptoms. So in other words, if you followed up 100 people, 60 of them or 66 of them would still have chronic symptoms, and in the other third, so the other 33 out of 100, their symptoms disappeared. There's always a possibility that people who've been told they have IBS will develop an organic disorder, such as colon cancer, inflammatory bowel disease, or celiac disease later on. This issue's been well studied, and these sorts of studies have shown that this risk of developing Crohn's or ulcerative colitis or celiac disease or colon cancer does not increase continually the longer one has IBS. It actually peaks in the first year or two after an initial diagnosis of IBS is made. And that really suggests that that's because the person has been misdiagnosed, so mislabeled as having IBS in the first place, and then one of these organic disorders is uncovered shortly after, presumably because their symptoms changed or got worse or didn't respond to treatment that the GP or gastroenterologist prescribed. There have been very few studies that have assessed whether IBS affects life expectancy, but again, in our study in Leeds, which included about 8,000 people, after 10 years, people with IBS had the same life expectancy as people without IBS. Thank you.
Thank you.
Thank you very much. Thank you. Well, thank you, Leonie, and thank you, Alex, for a sharp and interesting exchange. I think you raised a number of issues, Leonie, and thank you, Alex, for your excellent responses. Alex, before we start the questions, I just wanted to ask you, what's your bet for a test for IBS? Are we anywhere near it? Is there anything in the pipeline that actually you think might be a test for IBS? So
some of you may have seen, I don't know if it's been advertised in the newspapers or online, but within the last year, a scientist called Mark Pimentel, who works at Cedars-Sinai in LA, has developed an antibody test, which is an antibody to part of a bacterium. And they've tested this antibody test in people with diarrhea predominant irritable bowel syndrome, and they suggest that this test is very accurate. But when you actually, as a sort of scientist, when you actually start to look into how accurate this test is, it probably doesn't perform any better than listening to someone in clinic describe their symptoms, performing a few simple blood tests, and making a positive diagnosis. So it's actually probably a lot more expensive, and it is no more accurate than the kind of criteria that gastroenterologists and GPs use. Okay. But that test is now available in the US. When I get my journals from America, it's being advertised in between scientific articles that this is the IBS quick test or something, Peter, does that ring a bell?
I think it is.
That will confirm the diagnosis.
It's vinculin, isn't it?
Yeah, anti-vinculin antibodies.
Anti-vinculin, yes. So mentioning Mark Pimentel, what do you think about small intestinal bacterial overgrowth? A major subset of IBS? Or, you know, an artifact? What is your view?
So Lee and I were talking about this before we did our session. So I think the Cedars-Sinai take on this is that IBS is an infectious disease, I think, and that's what they tend to put in their information leaflet. This goes back to Mark Pimentel's work, which shows that some people with irritable bowel syndrome type symptoms have abnormal breath tests, and then from that he went, which are a potential marker for bacterial overgrowth, but they're not a very accurate test for bacterial overgrowth. But based on that work, he went on to treat some people with irritable bowel syndrome with this antibiotic called rifaximin and showed a benefit. And so now there's been these two big trials which show that rifaximin seems to have a benefit in IBS. I think most people would say that the benefit is very modest, and in the very big trials, none of the patients with IBS were tested to see if they had bacterial overgrowth in the bigger trials. They were just randomised to receive a placebo or rifaximin. There was no breath test. The gold standard test for bacterial overgrowth is to get a sample of the intestinal juices and send it off for culture, and that's an invasive procedure, so we don't tend to do that, and they certainly didn't do that in these big clinical trials.
Yes. Do you agree with that, Peter?
Yeah, and rifaximin also has anti-inflammatory activities.
Yeah. Sorry, my fault, Sam.
Yeah, rifaximin does have anti-inflammatory activities, so it may be completely unrelated to that.
Yes.
Just like you've been saying, Alex, I think a small proportion of people will have small bowel bacterial overgrowth. Yeah. But the problem is, if IBS is causing it, if the motility problem is causing it, getting rid of it, it's just going to come back again. Yeah. And that's one of the big problems.
Yeah, exactly. And so, you know, Mark Pimentel describes these patients who've been treated 8 or 9 times with rifaximin, and he says that there's no long-term adverse events, but, you know, keep on continual retreatment with antibiotics may not be desirable.
Yes. Okay, thank you for that. Sorry to jump in there. I thought this is an important area. Okay, let's open it up. What do you want to know from researchers? Vicky.
Hi, Leonie and Alex. Thank you. That's a really interesting talk. I'd like to ask you about research approaches that's used with people that have got IBS. You talked about how IBS fluctuates. Therefore, is a randomised control trial appropriate as a research methodology when our condition is really out of control?
I guess, you mean when your symptoms are bad, or?
Yeah, if we're trying to control patients in a trial, but the symptoms are here today, not there tomorrow, here again the day after, how can we get anything meaningful when really maybe the research approach isn't all that appropriate?
It's a very good point, and one which people are starting to look at in terms of symptom monitoring using apps and things like that. They haven't been used in clinical trials as yet. So yeah, we use a very imperfect way of assessing whether a treatment works in irritable bowel syndrome, and the way we assess it is based on recommendations in the US from what are called the Food and Drug Administration Agency, and in Europe they're called the European Medicines Agency, and they say that we should have usually what we call adequate relief of symptoms was the old term that was used, but now they've gone on to very complicated measures that include relief of abdominal pain, normalisation of stool on a certain number of weeks out of the treatment period. Most trials in IBS are short, I guess, is one thing to say. So they only ever take place for 8 or 12 weeks. There's been very few studies that have gone on for 6 months. So patients, I guess, when they enter a trial, if it's only for 8 or 12 weeks, it may be that their symptoms would have been bad for that period of time anyway. But over the longer term, you're right, when we see an improvement with a treatment or a placebo, it could just actually be that the patient's symptoms are going to start to get better anyway.
Okay. We've got several. There's Nick here who wants to ask a question. Here we are. Linda. And one over there as well.
Ladies first.
Oh, thank you. I didn't realise it was coming round so quickly. I've got two possibilities for areas of research which might be interesting. I know one of the speakers this morning mentioned an association between IBS and incontinence. So I'd like to know about any studies that have been done or in the pipeline about that. And also about the changing sort of presentation of symptoms over time and whether there's a difference between people who present very young and people who are rather older, and people who, like me, may have had some kinds of symptoms earlier or in their life, but then seem to have different sorts of IBS symptoms later. Thank you.
Do you want me to answer?
Yes.
So you're right, there haven't been very many studies that have looked at how many people with IBS experience incontinence. I am fortunate enough to be a handling editor for a journal, and at the moment I'm dealing with a paper looking at that very issue, which has been sent out for review, and I suspect it will be published. So there will be a paper looking at fecal incontinence in people with IBS, because it's well recognised in people with inflammatory bowel disease, but there haven't been many studies that have looked at that as an issue in IBS. You're right. In terms of, I think the second question was to do with, do symptoms change as you get older? I think IBS can affect anyone at any age, but generally it starts in younger individuals. So it's more likely to occur under the age of 45 than in someone who's over that age group. Whenever someone presents with a change in bowel habit over a certain age group, around about 45, 50, it usually triggers off what's called a 2-week wait referral because of a worry about bowel cancer. And so that person usually ends up having an investigation, seen by a gastroenterologist, and probably a colonoscopy. Any patient with IBS is just as likely to potentially develop bowel cancer in the future as someone who doesn't have IBS. So whenever anyone's symptoms change, particularly as they get older, my advice would always be that if symptoms change, for instance, you've always been someone who's been constipated, but you suddenly have a complete about face and are going to the toilet several times a day and passing blood, then obviously that would be worrying for a bowel cancer, and you should have, you should be referred and investigated.
Thank you. Nick.
Alex, hi. I'm keen on understanding if there, during your studies, been any correlation between IBS sufferers and a history of antibiotic use over time. So keen on understanding that, and also if there is such a correlation, should people be kind of afraid or try and avoid antibiotics, and if that's the case, how is it done without obviously kind of the detriment of continuing to suffer from something if you can't fix it via other uses?
That's a great question. I see lots of patients who, for instance, I can think of one person who had problems with wisdom teeth, had 5 or 6 courses of antibiotics, got diarrhoea, and then has been left with IBS ever since. And why that's happened is difficult to know. Is it a sort of what we call a dysbiosis, as would happen? I think you explained your case. I think you were the gentleman who said that you'd had some dodgy lamb meatballs. Yeah, as would happen after an acute enteric illness. There have been, very recently, within the last 2 years, have been a couple of studies published that suggest that people who've had antibiotics are more likely to develop IBS in the future. The problems with those sorts of studies are that the associations between antibiotic use and subsequent IBS are very modest, and these sorts of studies are open to all sorts of other biases that could influence that association that they've reported. For instance, it might just be that people who are going to develop IBS are more likely to seek help for a throat infection or something like that, and therefore be prescribed antibiotics. Or it may be that there are other drugs that are associated with antibiotic use that are also implicated in generating symptoms that sound like IBS. But I've definitely seen patients myself in my own practice, anecdotally, who have had symptoms that have been triggered by repeated courses of antibiotics, and there are some studies suggesting that there may be a link. So that's a great question.
I can see lots of hands up. Yes, there's one there. Yes, behind the pillar.
I have a particular interest in clinical research, and my question is really rather more general. You said that there were several calls out at the moment for research, but I don't know how those calls have been arrived at. Has anyone used the James Lind Alliance priority setting partnerships to arrive at the priorities for research? That is, for those who are not familiar with it, the partnership between clinicians, practitioners and patients to arrive at the top 10. Yes, and something that we should have done, I agree. So the James Lind Alliance were employed or consulted by the inflammatory bowel diseases section of the British Society of Gastroenterology to generate their top 10 research priorities for people living with Crohn's disease and ulcerative colitis in the UK about 2 years ago. And on the back of that, there have been a series of what we call themed calls from the National Institute for Health Research and the MRC for research into most of the 10 topics that were identified as key areas. For IBS, we haven't done that, and that's one of the things I was mentioning when I responded to Leonie, which is that we should be using, clinicians, patients, and other professions who are involved in IBS should be working together with someone like the James Lind Alliance to generate a top 10. That would be a really useful strategy and something that our section of the British Society of Gastroenterology should be employing, I think. It would be the it's the committee. So each of the sections of the British Society of Gastroenterology has a committee. So there's like an inflammatory bowel disease committee, a neurogastroenterology, which is what irritable bowel syndrome falls under, committee, a gastroduodenal committee. So the neurogastroenterology committee, and as part of the research committee of the BSG, should suggest that.
Okay, we've got time for one more quick question, please. Sam, you'll have to choose. You've got it.
Hi.
Okay.
Yes, Chairman Mao Zedong said knowledge is power, isn't it? And so I guess my question is, how do we empower the patient, the sufferer, to change from being in a position of passive recipient to active participant in the whole therapeutic process? And Alex has mentioned, and several other people have mentioned, scientific papers that have been or are about to be published. And as I understand it, any research that has been publicly funded now should be publicly accessible to the public, of whom we are a sample here. So I'm just wondering if there's a role for the IBS Network to be a kind of to flag these things up and to, give us links to research that's been published, how we access it. Because my experience over nearly 40 years of IBS, that I often, and this is without being arrogant, know a lot more than the professional I'm talking to about my symptoms and what may have caused it. So it's just
that's a really good idea, and we do, as the journal that I work for, which is Alimentary Pharmacology and Therapeutics, do provide often articles that are of interest are free. That's the first thing to say. So, and particularly articles that have been downloaded a lot and therefore are obviously generating a lot of interest are made free. And also our website is clickable from lots of other websites, but within the realm of clinical gastroenterology. So it may be that the IBS Network could enter into a dialogue, I don't know how easy this would be, with various gastroenterological journals about potentially making a selection of IBS papers clickable from the IBS Network website. I'm probably digging a hole for Nick here.
Well, I think you've raised an excellent idea.
It's a really good point.
Yeah, no, I think it's an excellent idea, and I personally get frustrated with myself because I can't get papers I want to get. I see papers that actually look really interesting, and I only get the abstract, and I can't go further unless I've got an account. And since I left the university, I'm not officially allowed an account, so it becomes frustrating. So I know exactly how you feel. I think it is something that the IBS Network could address. We always need, and I'm afraid I'm going to throw it back to you, we always need people to take projects like this forward. put it that way, because there's a number of projects. And, you know, if somebody like you is keen on developing something like this, we will certainly provide a platform for it and encourage it. So speak to me.
But you're right, that if a study is funded by the MRC or NIHR or someone like that, it has to be open access. Those are the rules.
Yeah.
You're right.
Yeah. Okay, that is the end of this session. Thank you very much, Leonie. Thank you, Alex. That's a useful session. Okay, Julie, come on up. Sam is going to introduce you.